Taking a look at the forearm extensor muscle group, starting from the lateral epicondyle, we can ask our patient to move into ulnar deviation and palpate through the belly of the extensor carpi ulnaris muscle. We can then move into the extensor digitorum by asking our patient to wiggle their fingers and palpate through the belly of this muscle down towards the wrist. We can then move into the extensor carpi radialis brevis muscle by asking our patient to move into radial deviation. The next muscle is the extensor carpi radialis longus, which does not originate from the lateral epicondyle. It attaches higher up on the supracondylar ridge. We can palpate through this muscle while also asking our patient to radially deviate. To start with the extensor carpi ulnaris muscle, again, we can ask our patient to activate the muscle by using ulnar deviation of the wrist, palpate through the muscle, find the tender spot, and then the needling direction is perpendicular to the skin, directly into the belly of the extensor carpi ulnaris muscle. Then moving into the extensor digitorum muscle, palpating through the belly of the muscle, and the needling approach is perpendicular to the skin. The extensor carpi radialis brevis muscle can also be needled perpendicular to the skin. To needle the extensor carpi radialis longus muscle, we use a pincer grip palpation, and this is due to the location of the radial artery that lies beneath the extensor carpi radialis longus muscle. The pincer palpation is to avoid entering directly into the artery, and we are just aiming towards our finger on the opposite side. An additional muscle that can be needled in this position is the brachioradialis muscle. This muscle originates from the supracondylar ridge of the humerus. We can use a pincer grip palpation directing our needle towards our finger on the opposite side. This will keep us well clear of the underlying radial artery.